Okay, I'm going to get started. Good morning. I wish we could all be together in person, but we'll make do with what we have. It's come to my attention recently that not everybody knows who I am. So I am Bill Hammond. I used to be a journalist. Now I work at a think tank. More specifically, I was a journalist for 27 years. The last 17 of which I was at the LCA in Albany. And then that includes 12 years at the editorial page of the Daily News. Now I work at the Empire Center where I'm Senior Fellow for Health Policy. I want to start by acknowledging that the subject matter here is pretty horrific calamity. A lot of people died. 45,000 statewide and 15,000 in nursing homes. It's a lot of people who lost their lives, a lot of people who lost family members and loved ones. So as I talk about the data, I want to sort of acknowledge that behind every data point, there's a person. And I think we owe it to those people and to the survivors and to ourselves to understand what happened as best we can, so that we can make sure it doesn't happen quite the same way again. I'm going to give a summary of our new paper and its findings, and at the end I'm going to take as many questions as I can. If you have a question, you have two choices. You can raise your hand and you'll be called on later. Or you can type a question into the chat. So I'm going to share my screen. So the background for the study is that the Attorney General's report, which came out January 28th, in addition to identifying an undercount in the deaths, it also looked at the conditions in nursing homes, and it found a link between nursing home deaths to the level of staffing in those homes, and also some evidence that the situation was worse in for-profit facilities, which are now a majority of nursing homes in the state. But that report was based on partial data. It omitted, not only did it omit the group that the state was withholding, which is nursing home residents who died in hospitals, but it also, their analysis cut off in mid-November, which was before a whole second wave that hit nursing homes in November, December, January. So in total, that report looked at about 6,500 deaths. The number of deaths that we now know about has more than doubled. So we went back, and in the meantime, the legislature has been advancing legislation, in part based on the Attorney General's report, that focus on staffing and ownership in nursing homes. And the governor has chimed in with his own proposal relating to for-profit homes specifically, and he intends to have that be part of his budget, which is going to pass in only a few weeks. So our concern was that we should consider what the new data says before we jump to any conclusions about what the right solutions are. So we did that. We crunched the numbers in the additional data that we obtained through a court order. And we found, with that fuller data, the relationship between nursing home deaths and staffing pretty much disappears. There's or at least I should say it disappears in the terms of the analysis that the Attorney General did. There's also, it's unclear whether there's a relationship between mortality and for-profit ownership for reasons I'll get into. Statewide, the for-profits did show higher mortality, but downstate in the Long Island, New York City, and the suburbs north of the city, The for-profits actually had a lower mortality rate as a group. And then upstate, they had a higher mortality rate as a group. One reason for that, one reason for these kind of these seemingly contradictory findings is that for-profits are concentrated downstate. They're concentrated in the areas of the state that had the most infections and deaths. And so that when you look at it statewide, you're seeing that effect. Another thing that may have played a role here is that for-profits admitted more than their share of the COVID positive discharges from hospitals that were sent to nursing homes under the March 25th guidance from the health department. And then the one group, if you look at it just the three big categories, for-profit, nonprofit, and government-owned as a group statewide had the lowest mortality rate of the three. But if you looked at the subgroup of state-owned facilities, that was the highest mortality rate of any subgroup. And a lot of the homes that are defined as state-owned are veterans homes. 5 out of the 7 are veterans homes. So this is the way the Attorney General's report framed the question of staffing. They took the Centers for Medicare and Medicaid Services do these nursing home care compare rankings. They assign a star value to each nursing home, and they assign a separate star value based on staffing levels. So the left-hand column shows the star rating for staffing levels for that group of homes, and the far right-hand column shows the overall mortality rate that the Attorney General was aware of when she did this analysis, or when her office did this analysis. So you can see that if you look here, this is the total number of deaths they were looking at, 6,600. And the overall death rate was 6.38. The highest death rate was in the 1-star facilities, which is the lowest rating, and the lowest death rate was in the 5-star. So her conclusion, which is reasonable based on this evidence, is that there was a connection between staffing and star ratings. We did the same analysis. So this is the same table, only now we have double the number of deaths, 13,000. And now when you look at it, the highest mortality rate is in 3-star facilities. The lowest is still in 5-star, but it actually, the ranking, if you want to say that, it goes 3-star, 2-star, 1-star. So no longer is there a clear connection between staffing and mortality. Here's another way of looking at that. The blue columns are the results in the Attorney General's, and you can see a slope going from 1-star down to 5-star. But when you add in the additional data, the benefit of our court order and the benefit of 3 more months of information, you can see that there's no longer a slope from 1-star to 5-star, that it reaches a peak at 3-star. So that's the basis for us saying we don't see a connection a clear connection to staffing. This is the picture on ownership. So for each of these groups, I have the number of patients who lived in the different categories before the pandemic. So for the 12 months leading up to the pandemic, the number of deaths in each group, and then the percentage rates. And you can see in downstate, for-profit's actually just slightly lower than government owned. I mean, it's a meaningless. There's essentially the same exact mortality rate between those two categories, and not-for-profits are a little bit higher. Upstate, it's a very different picture. For-profits have a much higher mortality rate than government owned, and a slightly higher than not-for-profit. And then statewide, you get that outcome. This is for the truly stout-hearted wonks out there. This is a series of regression analyses. Each column is a separate regression analysis that factors in different things. The upshot of it is that this row right here with the asterisks next to the numbers, those are statistically significant results. And so the COVID admissions, there is a statistically significant correlation between COVID positive admissions and higher rates of death. But for for-profit ownership, these little crosses mean there's no statistically significant relationship. The same with CMS staff rating, they all have crosses. But then when you get down to any new COVID admission, again, we're seeing a statistically significant correlation. These last two rows, the county fixed effect, that's a way of correcting for where the nursing home is. So if it's in a county with a high rate of mortality, you're kind of adjusting for that. And then this is the size of the facility, which is, you know, if you have more deaths in a large facility, that you would expect more deaths in a large facility. So this is the picture in the 7 state-owned facilities. You can see that 5 of them are veterans' homes. They're kind of spread around the state. The average mortality rate statewide is around 13%. So as a group, they had a higher mortality. And then the especially high mortality was in the Long Island State Veterans Home in Suffolk County. Suffolk County was a place where there was a lot of coronavirus. It got really bad there. I guess the reason I bring this up is, first of all, these are facilities that are under the direct supervision of the state and in some cases the health department. And so I think it's worth knowing that they compared unfavorably, especially given that the people involved are veterans, many of the people. But also I would point out there's no profit motive in these homes. And so I think the idea that the profit motive determined mortality, that this is a piece of counter evidence to that. So as I say, no evidence that staffing affected mortality, no evidence that the for-profit ownership affected it. There were high rates, and that raises a concern at the state-owned veterans homes. And so all of this leads to the idea that two of the major proposals that are being considered in the legislature revolve around setting minimum staffing ratios in one case, and in the other case, putting new limits on for-profit homes. The legislature's approach would be to cap their expansion, and, you know, to say no more for-profit homes will be licensed, and also that the existing ones can't be expanded. The governor's approach is to set rules about how they spend their money and to limit how much profit they can take. I want to say we're only looking at those factors with respect to one cause of death. We're only looking at the one quality measure in this case, which is dying of coronavirus in this particular pandemic. I don't want to extrapolate this to say that there's no connection between either for-profit ownership or staffing when it comes to overall quality. We're not looking at overall quality here. So there is research in those areas, and the legislature should pay attention to those research, but I don't think they should be presenting I don't think they should be presenting these particular proposals as solutions that would have saved people from coronavirus. They may have, but the evidence suggests that these were not significant factors. I think the most significant factor is just how much virus there was in the community. And if there was a lot of virus in the community, it got into the homes. There may be other things the nursing homes did that protected their residents. And so there was more than just random chance. And I think we should be investigating that. And maybe a closer examination would find evidence that staffing was involved. But the Attorney General's analysis was thrown off, I think, by the lack of data that was available to her office. For more information, you can find at empirecenter.org. And so now I want to throw it open to questions. Okay, I see there's a question from Tim Knaus.
Hey, Bill.
Hey, Tim.
I think your numbers that show worse mortality in state-owned facilities may attract some attention. So I'd just like to hear you say whether whether you think ownership was the key factor there, or whether it's complicated by the community transmission rates in those areas. How strong how strong of a correlation are you seeing?
I mean, it's a very small number of homes. It's 7 homes, so it's 7 observations, as it were. So I would be slow to draw conclusions that it was caused by state ownership. But I think it is something, there should be a certain amount of soul searching on behalf of the management of those facilities to figure out, to find out why did they, it may be largely driven by the community infection rate. It may be that their population is more frail than the average population. It's worth figuring that stuff out. Yeah, I mean, that's the basic answer, that there are any number. I had some other, I can't remember what I was going to say, but I think it should attract attention, because that the Long Island State Veterans Home, that mortality rate, just the absolute number, which is 120 something, is the second highest in the state. The only home that's higher than that was a COVID-only facility for part of the pandemic. As a percentage, the 37%, is that what it was? That was, I think, 13th highest. It's in the report. So it's way up there. And so even by the standards of that part of the state, it's high. There might be there might be explanations for that. I think we should know what those explanations are.
Thanks.
So I'm going to Bernadette.
Hey, can you hear me?
Hi. Yes.
Yeah, so I'm actually very interested in the state-run homes as well. So regardless if you want to say whether or not it was the ownership that attributed to the higher number of deaths, but what should the state be doing here? Because I mean, that jumped out to me as very interesting in the report. So regardless if you want to like peg it on the state, how are they managing these homes differently? I mean, is this again something that the state, like, I mean, what can they be doing to change that? Like, that seems to be pretty egregious, don't you think?
I mean, I cannot explain why those numbers are so high. That it's sort of, I wanted to draw attention to the numbers because it was a pattern that emerged from the data. The very first thing when I looked at ownership, the very first thing I did was I aggregated all of the residents of facilities by ownership categories and all of the deaths. And then I did the percentages, and the highest percentage was the state-owned facilities. I have to say I was surprised by that. The general pattern is that government-owned facilities did better. And in fact, the other owners of facilities, the counties and the cities that own those facilities, must be doing quite well indeed in order to offset what was going on in the state-owned facilities, which is what brought their overall rate down. There's not that many government-owned facilities in the state. It's fewer than 30. So the state is about about a quarter of the whole picture. But I don't have an explanation. I think it's I was hoping to provoke the kind of questions you're asking, but I can't answer them.
Right. I guess, like, what would you say about the state then? Like, what can they be doing better? Or, because I mean, you have some county-run facilities that are, they are pretty equitable to this, but you're not seeing this high of a death rate. Like, I'm thinking of like Steuben County, or sorry, Livingston County. They have like, I think something like 200 beds, but you're not seeing like this massive death rate that you're seeing in, I mean, you've got 457 on Long Island, but I guess, yeah, just back to the question, should the state be held accountable for this? What's
I
your
mean,
message to them?
I'm not really in a mode of trying to cast blame or even, I don't think we've gotten to the point of talking about accountability necessarily.
Mm,
I'm really at the mode of trying to figure out what happened. And this is it's this particular data point stood out for me. Yeah, I think it sheds a certain amount of light on this question of ownership, how much ownership factored into mortality rates.
mhm.
This is a pretty clear-cut example where profit was not on the table, at least I wouldn't think it was, and yet they had pretty bad outcomes. It could be they just got unlucky, but it could also be something that that they could fix, and it's, I mean, I don't actually know whether the managers of these facilities even know where they stand. I mean, you have to remember, it was only a couple weeks ago that we obtained the complete data that made this analysis possible.
Right. All right, thanks.
Next up is Joe Mahoney. Joe?
Am I on now?
Yes, you are.
Okay, thanks. Sorry about that. Early on, I think probably March, I don't have the exact date, but I remember seeing stories out of Massachusetts on a veterans home in Holyoke where there were dozens. It started out, smaller. I think it first hit the news at a certain number. I forget the number, but it grew rapidly. It was a classic example of fire through dry grass. So we had more than 50 deaths at one point. And there was a huge investigation that culminated in the arrest of, I think, 2 individuals involved in the management. There were, I think at least one of them was a political hack. But, given that that was in the news, and also Kirkland, which was not a veterans home, out in the state of Washington in a nursing home, before we even had our first documented infection here in New York State, that these should have been wake-up calls to those involved in the oversight of nursing homes, that this whole analogy of fire through dry grass, and that some extraordinary response should have been mounted to prevent further spread. And as we now know, based on the earlier hearings back in August, I believe Mr. Hance and others stated they didn't even have PPE, which, because they were caught off guard, everyone was caught off guard about this. But when you go back to March here in New York, they didn't seem to be reacting to these reports of nursing home vulnerability in a very aggressive way.
I mean, I think, first of all, I mean, it should be pointed out that everywhere this virus has gone, it's found its way into nursing homes, and it's had horrific effects. Those effects weren't even. They were, some homes suffered much higher rates of infection and death than others, but it's not easy to find obvious reasons for that. You see 5-star homes with high death rates and 1-star homes with low death rates. It is kind of interesting that you had such a serious outbreak in a veterans home just across the border in Massachusetts. Maybe there's something particular about the veteran population, about their health profile. Maybe it has to do with the size of these facilities. I believe the Massachusetts one was quite large, and the Long Island State Veterans Home is on the large size. It's not the largest in the state, but it's one of the larger ones in the state. So maybe there's something about a large scale facility that promotes infection. maybe there's something about the staffing patterns of a government-owned facility that, you know, they handle their staffing differently. The Long Island State Veterans Home, I believe, is managed directly by the State University at Stony Brook, but some of the other ones around the state are managed directly by the health department. So it's all worth asking about. I mean, I would agree with you that we underestimated the risk for nursing homes and we didn't prepare properly, and maybe even we made their protection secondary to worrying about hospitals. That seems to have happened as well. Those are all things, you know, we'd probably like to have back, I think. But really, I can only speculate about some of this stuff. I don't have any kind of answer.
Right. But and shouldn't it also matter then when these deaths occurred? So if you charted out the past 12 months.
I looked at that for the veterans homes,
Mhm.
and it followed the pattern that the rest of the state did. There was a high peak in the spring and then a second lower peak in the winter. So nothing jumped out about that when I looked at it. I didn't look at it super closely, but I did check that to see if there was. And the other thing is that the hospital deaths were a consistent portion of the total in nursing homes throughout. There may be some homes where it was higher than others, but at these larger homes, it was about a third. So it was consistently about a third. It was a third in the spring. It was a third in the winter. I did try to poke around for something that I could point to as an explanation, and I didn't find anything.
Mhm. And you've touched on this, so sorry, but I just want to, and this gets into speculation a little bit, and somewhat that is based on my own profiling, having grown up around a lot of veterans. But veterans, from my experience, tend to be, there's a very high percentage of people who smoke. So when you have frail older people from the Korean War period, or not too many World War II people left, but even the Vietnam era, very high percentage of smokers in those groups.
Well, you know, you get into something that should be examined and that I don't have access to, and that's kind of the demographics of these nursing homes.
Mm-hmm.
So, you know, you brought up smoking. There's also different nursing homes are going to have different racial profiles. They're going to have different economic profiles. You know, you're going to have more poor people in some homes and more rich people in other homes. You're going to have more people of color in some homes than others. And that could affect, you know, I mean, we know the patterns show that people of color and smokers and lower income people all are at greater risk from coronavirus, even whether they're in a nursing home or not. So those are all things that could explain a lot about why you're seeing variations between homes.
Well, then, sorry, I keep asking questions, but you know, shouldn't we be hearing more from the health department as to what they are going to do with this kind of data? Should they be conducting a study as to why Chenango Veterans Home had relatively few deaths per resident versus the one on Long Island, which had a lot of deaths? I mean, isn't that something that the state should be doing to find out what the lessons learned are from all of this, and why something happened?
That is actually a kind of overarching concern I have about this whole situation, is that not only is the health department, well, I mean, maybe the health department is doing that study, but they certainly aren't letting us know that they're doing that study. But not only is that study, like, it's unclear that that study is being done, but they've been working very hard not to share the data that would be necessary to do that study. Like, that the health department's role in this should be to be the kind of well-informed, scientifically careful agency that's putting the public health interest first. I'm sure actually that there's a lot of employees there who are doing just that. The thing is, it's what the public is getting out of the health department is not living up to that standard. At least it hasn't so far. And the battle to withhold this data and the things that were said about nursing homes while that data was being withheld, the misleading things that were said, I think undermine the credibility of the leadership of the agency in a way that it's going to be hard to get back. But that's, that is one of the implications of everything that's happened.
Okay, thank you.
So next up is Dan Telvock.
Hey, Bill.
And you need, yeah, there you are, Dan. Hi, Dan.
Hello, how are you?
Good.
This is really great work here. Thanks for doing it. I'm curious. I missed your talk earlier, so you may have talked about this, but I'm curious, did you take this data on nursing home mortality by CMS staff ratings and incorporate the size of each facility? Meaning that I would think the larger the facility with more employees, you have a higher rate of COVID in that facility.
That's an interesting thought. A lot of this analysis was done on an aggregate basis, so I just added together the total occupants and the total deaths of each group of facilities that I was looking at. There may be a connection between size of facility and, and as you say, the fact that you have a large facility means there's more people, which means there's more possibility that one of them is carrying the virus and then it spreads.
Right.
But I didn't attempt to examine that. Actually, maybe my co-author Ian Kingsbury, if he might have some perspective on that.
Is available and
yeah,
if I had your data, I might even consider doing it myself, because that's what I heard from a lot of people, that the loved ones that couldn't see their loved one in a nursing home were telling me that it seemed like the staff was spreading it, and it made me, and they said, made me wonder after I saw this, gee, it seems pragmatically, larger the facility, maybe the higher the rates, and it really doesn't have to do anything to do with staffing or star level.
There's I would like to get Ian to weigh in on this, but the another thing to think about is that a large facility, one of the solutions when you have an infection is to do what's called cohorting, and that means you physically separate the infected patients from the rest of the population, and then you have a dedicated staff who only work with infected patients, so there's no opportunity for them to spread it to the uninfected patients. That's very difficult to do at a small facility because you're short of space and you're short of staff. But at larger facilities can do that. In fact, some chains, groups of homes that had joint ownership did that on a large scale, and they created a COVID-only facility and they shifted their patients around. That's something you can only do if you have the resources. So I think it's an interesting question to explore. I did not attempt to explore it. Ian, did you when you did your thing that controlled for the size of the facility, would that have addressed this?
No. So what we don't know is whether facility size was itself a variable that may have contributed to mortality rates. We did, however, in those estimates, control for facility size. So whatever differences you're seeing across sector, like for-profit or government or whatever, within those estimates, we are accounting for how large they are. But, as to the question of whether the size itself might have mattered, it's an interesting question that we or someone else could certainly probe.
Bill, did you share this information with the AG?
She's free to have a copy of our report. No, I did not consult with them on this. But the data is most of the data that we used is on our website. It's basically, it just comes out of the database. Almost all of it just came out of the database that we obtained through the court order on February 10th. Did you have something else, Dan?
No, I'm done. Thank you very much.
Okay. So we have a question in the Q&A from John Cropley. The Empire Center is in favor of free market principles. Does that create a potential bias in favor of for-profit nursing homes, or even the perception of such bias? I mean, I can't talk about perception. I will tell you that I don't feel like, I mean, it was a pretty straightforward mathematical thing that I did. I added up the residents and I added up the deaths and I calculated the percentages, and I included in the report the fact that for-profit homes overall had higher mortality rates. I'm not ruling out the possibility that there is some issue there. One big point here is that we're only looking at one morbidity thing, the single virus essentially, in one set of circumstances, which was a pandemic. We're not commenting on how for-profit rating or staffing affects overall quality of nursing homes. That's like a whole, that's a big complicated topic that, you know, the legislature needs to do something about. I think the quality of our nursing homes is not what it should be. It's a difficult thing to figure out. It's difficult to measure the quality of a nursing home. I mean, maybe if you go there and you're visiting and you'll have a gut sense of whether it's a good home or not, but measuring it in a quantitative way is very tricky. So yeah, I guess all I can say is that I tried not to let any kind of bias infiltrate into this math. It's pretty straightforward math, and you can check my results yourself if you want. I don't see any other, am I missing something? I don't see any other hands raised. So I'm, you know, we have more time and I'm happy to answer any questions if people have more. Oh, there's one, Joe Mahoney, back to Joe. You need to unmute.
On the inspection issue by the state, and this goes, I think, beyond the scope of the report, but you may have some thoughts. There seemed to be a reluctance to be aggressive with taking action when there were deviations, violations from standards, because, and I was hearing this from people involved, families, etc., that they were told, look, if we close down a home, we have no place to send these people. So even when they knew about substandard conditions, they felt that there wasn't much they could do. And plus the homes had immunity. Did that create, and it ended up breeding problems, increasing the risk, increasing the vulnerability? Any thoughts on that?
I mean, that's not something that I've looked at. Certainly it's not looked at in this report. I mean, it stands to reason that, I mean, I think it was just true that in the heat of a crisis like that, where, I mean, certainly in the spring, nobody was going anywhere. People were staying home. People who needed hospital care weren't going to the hospital because they were concerned about coronavirus. And the idea that you were going to move a frail elderly person out of a nursing home into some new environment under those conditions was, I mean, it was just going to be very difficult. And so there was a situation where closing a nursing home may have been worse than whatever the problem was that the nursing home had. It may have had outcomes. So, I mean, I do think the state's oversight of nursing homes needs a kind of top to bottom review, how it compensates them, how it regulates them, how it inspects them. Every piece of it should be on the table, because it's not, I mean, I don't think anybody would say it's working well right now. there are good homes, and then there are a lot of homes that aren't that good. And it's like a pretty high responsibility of society to do this right. Where the pandemic did expose some weaknesses in our nursing home infrastructure, clearly. I guess I wouldn't leap to conclusions that they were directly related to the bigger picture of quality, because as we've said, high rated homes had high death rates, and low rated homes had low death rates in some cases. It seems to be a little bit all over the map. And that tells me that this virus has unique properties that, you know, the regulatory regime that you have in a non-pandemic period would be focused on other things. It wouldn't necessarily be focused exclusively on one particular virus that happens to have asymptomatic spread. So you wouldn't necessarily expect your normal regulatory regime to be perfectly suited to defeating a virus. And so there may be overlap between the solutions that will protect you from a virus and the solutions that will make a nursing home better overall, but there also may be, they may not overlap.
Look at this.
Anyone else? Well, if we have no more questions, you can always reach me at the Empire Center, Bill H at empirecenter.org, and most of you have my phone number. And so feel free to call if you have any follow-up questions. But unless I see any more hands, I'm going to say that's it. And thank you all for attending.